Hey everybody, let's talk today about lumbar microdiscectomy. What you'll notice as we go through these postoperative procedures, there aren't a lot related to the spine. So we're going to talk about basically like 1 or 2 for the cervical spine, and then 2 or 3 for the lumbar spine, and that's about it. So when we talk about the lumbar spine here today, I want to spend a lot of time just talking about anatomy and maybe changing the way you think about herniated discs, because it's definitely one of those things that freak people out, freak a lot of our patients out in China. So I really want to dispel that idea and kind of change the way that we educate our patients related to having possibly a disc problem. A lot of the patients don't even have disc problems, even though maybe they present with one on an MRI. So that's what I think is interesting about these patients. And when it's appropriate to actually get surgery for a herniated disc, is going to maybe change the way you look at this. So we're going to do lumbar discectomy in 2 different presentations. Today we're going to go up through the surgery, and then the next time we talk, we'll actually talk about the rehabilitation following a microdiscectomy. So as we consider the idea of any type of surgery for the lumbar spine, we need to recognize the decisions that the surgeons are likely making related to deciding on if surgery is appropriate. And as therapists, we need to consider this because we may be seeing these patients before they've even considered surgery, or we may be seeing these patients if they've decided they don't want surgery. And so if we're seeing any of these red flags, we need to make sure the patient understands that it would be more appropriate for them to do surgery than to do rehabilitation. So surgical indications generally for any type of lumbar surgery. So again, these are things that are really important red flags that we need to recognize if we're seeing these patients. And that would include what's called cauda equina syndrome. And cauda equina syndrome happens and is pretty obvious to see in our setting as a problem with the lower extremities that's related to the low back. And so what that usually looks like is bowel or bladder incontinence. So these patients are going to say, you know what, I have had trouble controlling going to the bathroom over the last couple of days or weeks. That's definitely something we need to be sending them to a surgeon, to an emergency room, something like that. And then the other thing that we might see is this idea of a progressive motor deficit of the legs. And so meaning like all of a sudden I can't lift my leg up, all of a sudden I can't lift my toes up. Those kinds of things are going to be those red flags where we say, okay, this is something obviously related to something that we can't fix, and so we need to send you back to a surgeon or an emergency room. Other things that we need to also consider as we're rehabbing our patients is this idea that if they have radiating pain, we're going to see that a lot, but if they're having radiating pain where there are significant myotomal or dermatomal problems, especially myotomal. So if they're showing significant weakness of certain muscles related to possibly a nerve root problem at the lumbar spine, then this is where surgeons generally consider performing some sort of surgery for this patient. Also, they may be sending them to you first. So if it's not that bad, so they have the radiating pain, but they don't have high irritability and they don't have significant muscle weakness, you may be seeing them, you may be having them referred to you from a surgeon. And if you're providing treatment for 2 to 4, even 6 weeks, and they're not making huge improvements, then this is another situation where they may consider surgery. So let's talk about why they do a microdiscectomy. Microdiscectomy basically means that they're taking out a small part of the disc that is likely impinging a nerve root. And so it's affecting the ability, again, to walk. There might be strength changes or sensation changes in the lower extremities. And so this tends to happen, this disc herniation tends to happen with some sort of trauma. And usually it's happening with bending, lifting, those kinds of things, maybe twisting. But it also can happen with repetitive activity, so micro trauma. So if they are a person who has a job where they're doing a lot of lifting and they just happen to lift wrong one time, and the disc tissue has already been compromised in some way, then that might lead to a disc herniation. Prolonged exposure to vibration is another situation. So again, we have these factory workers, which I know a lot of you guys are seeing patients who are injured workers. And so they've been exposed to vibration in the factory for different reasons. Maybe they drive a forklift, something like that. And so that's going to lead to a disc herniation. Or maybe it's sports related. So again, they're doing these certain movements that are leading to putting more pressure on the disc. And we'll talk more about that in detail in a second. So what they're going to present with is this idea of radiating pain. And for those of you who have done any of our other classes, you know that radiating pain is actually a pattern that we talk about for the lumbar spine and the cervical spine. And that really means that there's a sharp shooting pain down one arm or one leg. They also could have non-radiating pain, which is what we call referred pain, and that could just be coming from the disc. And again, a lot of times we don't perform surgery for those patients because again, it's not changing their muscle strength, it's not changing their sensation significantly. So this is what you need to think about for those patients and consider this idea of, again, referring them to a doctor if they're showing significant symptoms of weakness or difficulty walking, balance problems, or significant sensation problems. So let's talk a little bit more about disc anatomy. We're not going to go into a lot of detail. Again, this is kind of part of a separate class, but what we do need to kind of remind ourselves about is this idea of the disc being two different parts. The central part is the nucleus, and the outside part is what we call the annulus. And the nucleus is mostly water, and the idea is that the nucleus transmits pressure from that central portion into the annulus. And so the annulus is made up mostly of collagen. And if you remember when we talked about ligaments, we talked a lot about the fact that it's mostly collagen. And so that's kind of why we put disc pathologies into this particular module, is because it's also very similar to, in composition, to what a ligament looks like. What's happened is as we get older, the annulus and the nucleus start to look very similar. And so we don't expect a lot of disc herniation problems as people get older, generally over the age of 60 or 70, because their disc now has turned into mostly annulus fibers, and there isn't the likelihood that it can actually rupture or actually have any type of injury. This is a picture that kind of shows that idea of the nucleus and the annulus, and the nucleus being in the middle, and it's kind of like a ball bearing, meaning that there's a ball that gets a little bit flat and changes as we add compression to it. And so we lose height in the disc from that ball as the day goes on. And I'm sure you've heard that before. You know, patients will talk about how, I woke up and I was this tall, and then when I was going to bed, I was only this tall. And that's literally because we lose the fluid in the nucleus portion of our discs throughout the day. And so as we get older, we have a lot less fluid. And so again, we tend to kind of shrink down a little bit throughout the day. But that the annulus is really allowing to take on the pressure that the nucleus gets throughout the day with things like rotation and just weight bearing. And so what we need to recognize is that the disc itself moves in the opposite direction of the movement that we do because of that fluid portion of the nucleus. So I have a couple pictures here. This is the first one, and it kind of shows how when we bend forward, the nucleus and the disc itself actually moves posteriorly. and when we bend back, it moves anteriorly. And that's important because we do have nerve roots, we do have nerves that are in the posterior portion of the vertebrae that can get compressed with bending forward and actually get relieved with bending back. So this just provides you another picture of that same idea. And you can see here that, again, with extension in the first picture, that the disc and even the annulus, basically the nucleus and annulus, move anteriorly, but with flexion they move posteriorly. And so it can cause more compression on the tissues that are in the posterior portion of the vertebrae. What you see here is actually oftentimes the mechanism of injury for a disc herniation, and that tends to be some sort of compression and rotation at the same time. So those annular fibers allow for rotation, but if they get put too much strain on them, then it can actually lead to some sort of herniation or bulging of the disc. And that's usually a movement that combines flexion with rotation, and that's the situation where the annulus is actually at its weakest. And so you have compression of the nucleus, but you also have more stretching of the fibers of the annulus. So that's where a lot of patients, if they're talking about their mechanism of injury, they're going to talk about the fact that they were bending and maybe doing a little bit of twisting. And maybe they've done the same movement multiple times and didn't have a problem. But unfortunately, at that point, the muscles that stabilize were weak, possibly even the tissue within the disc was weak, and so therefore we get that disc injury. And so again, what happens with a disc herniation is that we get injury to the nucleus and some sort of tear in the annular fibers, usually. Sometimes it's just a movement of the nucleus that causes compression on the annular fibers without a tear. And this tends to happen in a certain age group of people. They tend to be people between 40 and 50 years old, where their other joints and maybe the muscles around the spine are more stiff because they're older, but they still have that good fluid within the nucleus. And unfortunately, that can then lead to decreased movement around the vertebrae and the disc, but lots of extra movement within the vertebrae and disc, and so that leads to then those disc herniations. And so what you find again as you get older, so even over the age of 50, I know I said 60 or 70 earlier, but even over the age of 50, when we lose that fluid in the disc, then we don't have as much likelihood of causing disc herniation. So if you've got a patient who's 70 years old and they're telling you, oh, I have a disc herniation, you know what, you can say, that's probably not their problem. It's very, very unlikely that that's what's leading to their symptoms. And we'll talk about other possibilities at that age group for symptoms that could lead to a microdiscectomy, but it's that less likely that it's a disc problem. So let's look a little bit more at this. I don't want to go into a lot of detail. Again, this is kind of a different class, but what I want you to recognize is that we do see a lot of patients in China who are going to come to you and tell you they have some sort of disc pathology, and that really wasn't the problem that they're presenting with. And the reason that is because they've gotten an MRI. Everybody in China gets a lot of MRIs, and that MRI showed that there was a disc bulge or herniation or something. And so that's what they think is the problem. And what happens a lot of the time with these younger people who are healthy is that we actually end up with healing that occurs. And if they were to do an MRI a month later, maybe 2 months later, they would notice that the disc is not herniated any longer. So this is why it's really important that we're listening to the patient's history before we diagnose them as a patient who has a referred pain disc problem. So what you see in this picture is that it's very common for us to have what's called an end plate fracture. So if we compress the disc in a certain way, we just end up with just a little bit of injury to the annulus. And the injury doesn't go outside the annulus. It literally just stays in that area. But if we end up having issues with bone and cartilage around it, then we can get what's called disc degradation. And so what that means is that we end up with pressure through the nucleus that presses and starts to injure the annulus. And so again, if you have a healthy disc and you're a healthy person, it might just be an isolated disc reabsorption, which is what's on the bottom left here. And that literally means that you might have actually caused too much pressure to the disc, but the disc is able to fix itself. If not, and the disc is not healthy, or there's issues with the tissue around the disc, then we can end up with some sort of radial fissure. And what that is basically what you see as the right on the right side bottom, a herniation where you actually do have tissue that goes outside of the disc. And when we start to really notice symptoms is when we get nerve root impingement, so something that actually happens to the nerve root. If this herniation occurs and doesn't affect the nerve root, then we end up with what's called referred pain. And that means that you end up with this kind of outside pressure of the disc around the tissues, but not directly on a nerve root. And that referred pain can follow certain patterns in the leg. And this is going to be different again than radiating pain. This is a very, very old picture, like probably 100 years old now. Maybe not quite that old, but it's showing people that unfortunately were injected with some sort of saline solution, so like a saltwater solution, in certain discs that allowed for the disc to irritate the outside tissue. And then these patients were asked where they felt the referred symptoms. And so you'll see here, this is referred pain at different levels of the lumbar spine, from L3 to S1. And these people will complain of sort of more generalized pain that goes down the leg. And you'll see that oftentimes these injuries happen at L4 or L5. And when that's true, those discs will refer down to the back of the leg, usually, sometimes front of the leg, all the way down to the foot. And so that's something we need to think about when we're trying to rule in or rule out referred pain versus radiating pain, and then provide postoperative care or non-operative care. The other reason that a microdiscectomy might occur is when there's a pathology called spinal stenosis. Spinal stenosis is something that we tend to see in older patients. So as you can see here, over the age of 50. So if they're demonstrating referred pain that you think might be coming from a disc, they tend to be younger people, again, because that disc is more viable at a younger age. But as they get older, they're more likely to present with spinal stenosis. And basically what this is a narrowing of the foramen, or the hole, that is related to the nerve root or even related to the spinal cord. So when it's a nerve root problem, and basically we're getting narrowing around the nerve root, then they're going to demonstrate radiating pain down the leg, just like they might do if they have a disc injury that is pressing on a nerve root. So again, we don't have time to go into what radiating pain is during these presentations. We probably can talk about it in lab if we have the opportunity. But if they're pressing, if the stenosis is occurring on the central spinal cord, then they're going to demonstrate those things like cauda equina that I mentioned earlier, where they're having trouble going to the bathroom, controlling going to the bathroom, and they may have some numbness and tingling around their sacrum. This also can be caused by degenerative changes. So if the disc is degenerated, which again is a pretty normal problem in older people, if the vertebrae has degeneration or any of the ligaments have degeneration, then this can lead to issues with the nerve root or the spinal cord itself. So this is a common problem. As you can see, it's 20 to 47% of adults over 50 are going to have some stenosis. It's just a matter of, does it affect them in a daily life situation? So is it affecting them with their movement? When you see that, the patient is going to basically tell you that they have to walk a little bit wider because they're worried about their balance. They also feel like if they do more extension with things like walking or standing, that they have more symptoms. Because again, stenosis is going to affect the nerve roots, so that's in the posterior part of the spine. And so if they're telling you that when they extend or stand up straight, that they have more symptoms, then they also feel better when they're sitting or going into more flexion. I really do consider this idea of stenosis as being the problem. Also, when you palpate the spine, you might feel that the lumbar spine itself is not moving very well into extension. So again, this can occur from lots of different possible issues. All of these issues, either stenosis or a disc herniation, can come from things like lifting, vibration, we already said, some sort of strain, some sort of twisting. What we find with anybody who requires a microdiscectomy, they're likely younger people because, again, as they get older with some sort of stenosis problem, they're not going to necessarily try to change the disc. They're going to try to change the bone around the disc. So for those patients that need a discectomy, meaning that they're removing parts of the disc, they're going to be the younger people with the herniated discs. So they're going to be between 20 and 50 years old. And I think men tend to perform the activities that lead to herniated discs more than women. And so they're the ones that we tend to do surgery on more frequently. So for diagnosis, we're going to use the same diagnosis we might use for referred pain pattern. And again, we're not going to go into detail about that pattern, but that is part of our low back pain guidelines. MRI is obviously used a lot in China, but we need to talk a little bit more about MRIs and the appropriateness of using that for diagnosis. What you can see from a physical exam that you might be able to perform in your clinic is this idea of these patients often demonstrate decreased lumbar lordosis. So they're going to be in a little bit more of maybe a posterior pelvic tilt, a little bit more of a flat back, and they're not going to be able to extend their back very well. If you've worked with any of the McKenzie theories, you'll notice that McKenzie also recognizes that these patients often demonstrate with a lateral trunk shift. So they're either going to shift away from the pain, or sometimes they actually shift towards the side that has the referred pain, but it depends. So you're just looking for that trunk shift that might be occurring. And then what's most important with referred pain patterns is that you're able to what's called centralize or peripheralize their symptoms with certain repeated movements. And so most of the time, as we talked about earlier, flexion is going to lead to more pressure on the posterior part of the vertebrae, and so that's going to likely lead to more symptoms, whereas extension is going to take the pressure off of the posterior part of the vertebrae, and so it might lead to decreased symptoms. So these patients, if they're demonstrating pain down to, let's say, the knee, if I do extension maybe 10 times, that actually causes the symptoms to decrease in the leg down to the knee, but it might actually increase the symptoms into the hip or the low back. And so that's called centralization, and that's something that we can use to test whether or not this is a disc problem. And again, we're not going to go into a lot of detail about that, but this is a way for us as therapists to be able to say, okay, this truly is a disc problem. And so this patient telling me that they have a herniated disc from an MRI, that's actually what they're presenting with, versus somebody who might be presenting with something totally different, like a movement coordination pattern or a radiating pain pattern. So when we look at the research, and there's a lot of research out there that's going to tell us something very similar. There are a lot of patients who will come in and say they have a degenerated disc. And usually these patients are over the age of 60 or 70. And what you can see here is that the percentage of patients with disc degeneration over that age is very, very, very high. So after about the age of 60, 88% of patients are going to have degenerative discs. And the way that we kind of describe it is it's kind of like saying you have wrinkles when you get older. and that's just a normal part of aging. Degenerative discs are also a normal part of aging. So again, we're looking more at their symptom presentation, myotomal, dermatomal weaknesses, things like that, as being reasons that they need rehab or surgery, versus if they just show disc degeneration on an MRI. The same thing is true for disc bulging. So you're going to hear about disc herniation, disc bulging, and what you'll see is that this is a group of patients with no pain, and over the age of 60, 69% of them have some sort of disc bulging. 77% of them over the age of 70 have some sort of disc bulging. And that, again, is probably likely older injuries, because we don't tend to have disc injuries in our older age. So this is something that might have happened when they were young and it just hasn't changed. But that MRI imaging that shows that they have this is not necessarily indicative of their symptoms. So you really need to listen to their symptoms and treat the symptoms and not listen to the MRI. So we're hoping, and I've seen this in China, that most surgeons are good at recognizing when the symptoms are related to a disc herniation, a disc bulge, degeneration with stenosis, versus when symptoms are related to something else. And if the patient is fearful and scared about this, these are the kind of statistics that you can give them. Look, this is very common at your age that you have this problem. What you're showing us is something different. Maybe you're showing us a movement coordination problem, or you're showing us radiating pain related to the nerve, and we can actually help with that. So it's really important that we're educating our patients on that. And we'll talk more about that as we keep going through these spine surgeries. Again, the pain science behind all of this is a much bigger topic that we don't talk about through this class, but it is something that we do present presentations on. So if you're interested in that, make sure you let the USC group know that. So if these patients, if the doctor is recognizing that there's not significant myotomal or dermatomal weaknesses, then they're going to likely do they're going to recommend non-operative treatment. It's really important that throughout non-operative treatment, you're watching those neurosymptoms. So you're looking for things like cauda equina, or those weaknesses, or radiating pain that we talked about that leads to significant sensation changes. But most of these patients, if you're seeing them non-operatively, are going to be part of this referred pain group. They also could be, if they're older, part of the radiating pain group, because there's stenosis that's leading to irritability of a nerve root. So if they're referred pain, as I mentioned earlier, you're going to want to do exercises that promote centralization of the symptoms. So bringing those symptoms out of the leg, but maybe increasing them in the hip or the low back. And those are what we call McKenzie exercises, so that repeated movement. If there's radiating pain, then you're likely going to be performing some sort of nerve glide. And if we do have the opportunity to review all of these things in lab, we will definitely do that. The other big important thing is that these people will likely need increased mobility in their hips and possibly their thoracic spine, usually their lower thoracic spine. And so that becomes another part of our non-operative treatment, is making sure we have good mobility in the areas where we don't have this injury. We also are going to spend a lot of time on patient education. There's a lot of references that we give you some of the list of references at the end of this presentation. There's a lot of references that talk about how important it is to explain to the patient that disc bulges and degenerative discs are very, very common, and that it's normal to have that. And so they need to recognize that might not be where their symptoms are coming from, and that a lot of the patients who do have disc bulges, those symptoms go away, and those disc bulges actually heal within the year. And so you don't have to worry about that bulging of the disc. So again, centralization movements, nerve glide movements, those things are our primary treatment for this patient population non-operatively. And then the other big piece is the cognitive piece. So if these patients are fearful, if they have been told for years that they have this awful problem in their back, but you're recognizing that it's not the problem, that a lot of your time is spent on patient education and being aware of stress management and decreasing that sort of idea of irritability. And again, this is kind of part of a separate class, so we're not going to go into a lot of detail about this here. So a surgeon is going to choose to do surgery, and you may have some conversation about this with the surgeon as well, is if there's a significant amount of spinal nerve impingement that's leading to those myotomal, dermatomal weaknesses or sensation problems. And then, like I said, the cauda equina, impaired bowel or bladder function, and then just leg pain that has not been improved with our conservative treatment, with performing the physical therapy that we could perform non-operatively. So I do have a video for this one for microdiscectomy. I've seen it multiple times in China. There's some great surgeons doing this surgery. It is very minimally invasive, meaning that they usually perform it as an outpatient procedure, even in China. So you're going in the morning, and what they're doing is they're putting a small incision posteriorly at the level of your spine where you might have the disc problem or the stenosis problem. And in this case, they're removing a small amount of disc material that might be causing compression or irritability on the nerve root. They may also remove bone, again, if there's more of a stenosis problem. They also might remove bone to get better access to the nerve and the disc. So you may end up with what's called a laminectomy, meaning that they cut through the lamina. And it's not a big deal. You have so many muscles that are controlling that area that it doesn't affect you in any way. And as I said earlier, it's typically outpatient, so they're going to go home the same day. I know it's not normal in China for that to occur, but with these patients, they tend to be young. And again, you're more aggressive and sort of more well-informed surgeons are going to do this procedure and send the patient home the same day. They're not going to even have to stay in the hospital. So let's look at the video of what the surgery looks like.
A herniated lumbar disc can push on spinal nerves and cause severe shooting leg pain, numbness, and/or weakness. A percutaneous disc removal can remove a portion of the herniated disc that is compressing spinal nerves through a small incision in the skin. This minimally invasive approach uses a much smaller incision than traditional open spinal surgeries and avoids damage to the low back muscles. A short incision, approximately 2.5 centimeters or 1 inch, is made to the side of the middle of the lower back. A device that projects live X-ray images onto a screen called a fluoroscope is typically used to pinpoint the exact position on the spine where the surgery will be performed. Next, a thin wire or needle is inserted through tissues and muscle to the level of the spine. Special dilators are guided down the wire to separate muscle fibers and provide access to the underlying spine without cutting through the muscles. After the initial dilator is docked on the back of the spine, larger dilators are added, gradually increasing the diameter to allow enough room for the surgical procedure. A retractor device that can expand the surgical field and hold back the muscle is placed over the dilators. The dilators are removed, and a lighting component is attached to illuminate the surgical field. A hex screwdriver is used to open the retractor blades, holding the soft tissue out of the way. The surgical exposure is now complete. An endoscope or microscope is then added to the edge of the retractor to provide close-up imagery on a screen to help guide the procedure. Through the opening in the retractor, the surgeon is now able to remove portions of the lamina and facet joint bones. Removing bone here allows the surgeon to access the disc and compressed spinal nerves. A grasping instrument is used to remove the herniated portion of the disc. Removing the herniation relieves pressure on the nerve root. The surgical instrumentation is removed, and the incision is closed and dressed to complete the surgery. Patients usually notice rapid relief of leg pain. However, numbness may occasionally persist for several weeks before fading away. Patients should take care to avoid heavy lifting and strenuous exercise for at least 6 weeks following the procedure.
Okay, so you can see it's a relatively basic, I mean, it's not basic, it's the spine. So, of course, your patients are going to probably be fearful of this type of surgery. But again, the surgeons that I've seen in China that have been educated well do a very, very good job. These patients can usually go home and we can see them in an outpatient setting. And I've even done exercises with them immediately after the surgery. So that's kind of exciting, kind of different than a lot of the other surgeries post-operative that we see here in China. But there are some complications. I'm going to finish up with these complications. Infection does happen somewhat irregularly. It's not very common. DVTs, just because the patient's not moving, they may end up with a deep vein thrombosis or some sort of pulmonary embolism, but it's very rare. I don't see a lot of complications with this surgery. It tends to be a very, very well tolerated surgery. So let's end there for this presentation. Next time we talk, we'll actually talk about the rehab that we perform following this type of surgery.